able to view my screen. So as Julie said, I work at Kenyatta as an obstetrician gynecologist, but specifically with a bias towards gyno-oncology. So today's topic is an area we looked at a while back with regard to gynecological malignancies. We had a series in the month of June, but since we are celebrating ovarian cancer this month, we felt it wise to do a recap on the issue of this disease because it's a major cause of morbidity among women. So in terms of guide, we look at a brief epidemiology of this disease, the pathology of this disease also, and how...
Sorry, Dr. Musalia, may I please interrupt you?
Yes.
I'm able to see your screen very well. I wanted just to request that you increase your volume if possible.
Oh, the volume, I can.
Yes,
yeah.
If there's a way you can be able to increase it. Thank you.
How is it now? Is it better?
Yeah, it's fair. Julie, how are you finding it on your end, where you are seated?
Probably she's muted, and I'll try to raise my voice so that I'm more audible. So, as I said,
okay, thank you.
Yeah, we are going to look at the epidemiology of this disease, the disease burden, and the pathology of the same, how patients present to us, and how we can make a diagnosis of this disease, and then do a little recap on the management of the same and follow up. Then Julie will come in and look at the nursing aspects of patients who present to us with ovarian cancer. So broadly, ovarian cancer is a term that refers to malignancies arising from the ovary. And the ovary is an organ of reproduction. We know this is where women will get the hormones which regulate the menstrual cycle, and also the oocytes, which are important in fertilization. So as an organ, it has multiple tissues, and from these tissues, we get various malignancies. So when we are looking at ovarian cancer, essentially, we are looking at very many disease entities, but grouped together as cancers of the ovary. So that you have to keep at the back of your mind. And because there are many disease entities broadly classified together as ovarian cancers, they behave different in terms of a clinical presentation, risk factors, the response to treatment, and the survival outcomes. So often when we are looking at ovarian cancer, we encounter certain challenges with regard to diagnosis, because the ovary is hidden deep within the pelvis. It is therefore not accessible to routine palpation during clinical examination unless it is markedly increased in size. So often by the time you are able to pick an ovarian mass, it is usually advanced disease, and hence the outlook sometimes for these patients is not very good. The other thing to keep at the back of your mind is that because it is a hidden organ, then we do not have a good screening tool for this disease. So we'll go further and look at the statistics with regard to the disease burden. It is the 6th most common cancer in women. We know breast cancer is the commonest. It is more common in the developed world, probably because of dietary issues, but it is also common here. I think we'll look at the statistics. But I think what we tend to see a lot is cancer of the cervix. But ovarian cancer, if you come to our oncology unit at KNH, is quite common. If you had 10 patients, probably 2 or 3 of them would be having ovarian cancer. And so this is a slide I picked from our locus data. And although it is a bit busy, but if you looked down there, you can see ovary in purple. The commonest cancer in women being breast cancer, followed by cervical cancer. And the ovarian cancer coming in there as number 5. But if you have to look at it in terms of gyne malignancies, then it is number 2. So it is quite common. You can see around 1,000 women die of ovarian cancer annually, as compared to cervical cancer, where we lose almost like 50% of those listed there. One of the things you'll find is that many times women diagnosed of ovarian cancer will most likely die of the same, because although they may get survival, but the disease often recurs. So we'll briefly now look at the pathology of this disease in terms of the specific cell types and the various classifications we have. So the ovary, as we said, is an organ of reproduction. I'm sure all of us as health workers have had a chance to see an ovary, either when you're assisting in theater or you're the surgeon, you're operating. We know how the ovary looks like. It is a small organ, pea-sized, located deep in the pelvis. It is usually, we say, without a capsule, but has an epithelial surface from which we get tumor. And then there's a deep substance of the ovary where the follicles are and the oocytes. We call it the stroma. And from that stroma, we get what we call stromal tumors. That is the second classification. So we have the surface, just on the surface, where we have an epithelial covering. There we get surface epithelial cells, and those account for the majority of the ovarian cancers. And then within the substance, the stroma, where we get steroidogenesis and the folliculogenesis, we have now the cells called stromal tumors. Then within the ovary, we will have germ cells, and these are primordial cells, which now give us another class of tumors that we call the germ cell tumors. And then we can have metastasis to the ovary from other structures, commonly the GI, or sometimes even the breast, and those we call Krukenberg tumors. So you can see Krukenberg class of tumors listed down there, arising either from the breast, lung, colon, and spreading to the ovary. So a little bit more about this classification of ovarian tumors. As we said, we have the ones that come from the surface, and these are called epithelial ovarian tumors. And they may be benign or malignant, but for the sake of the discussion today, we are looking at these tumors which are now malignant in nature, and they form around 80% of the ovarian cancers. Then we have the germ cells, as highlighted, the sex-cord stromal tumors, and the other rare tumors, which is said could be metastatic to the ovary. So this is a little bit more detail on the germ cell tumors. And as we look at the age distribution and risk factors, germ cell tumors tend to occur in the younger woman, often less than 30 years, sometimes even prepubertal girls. And because they arise from the primordial germ cells, they tend to assume the nature of all the tissues of the body. So you'll find germ cell tumors, when they are, say, like teratomas, they may have things like hair, teeth, skin tissue, bone, But if they're immature, then you might miss out on these things because it depends on the degree of differentiation. Often these tumors respond well to surgery, and they are usually diagnosed early, and usually even when there's a bit of spread, they respond well to chemotherapy. So these are the germ cell tumors. Then we have the sex-cord stromal tumors. These are the tumors which arise from the follicular cells surrounding the maturing oocyte. And we know these cells are either granulosa or thicker cells. So there are various cell types here, but the commonest is the granulosa cell type tumor, which might be what we call adult or juvenile. Adults often occur in the elderly women, usually above 50 years, but the juvenile ones will find them in the young girls. But the reverse can also occur. You can find the juvenile type occurring in the adult woman. The differentiation has to do just with the degree of cellular differentiation. So when they occur in the pubertal girl, then we could get precocity because of the elaboration of estrogen. However, if they occur in the women of reproductive age, because they are producing hormones, estrogen, testosterone, progesterone, then you get irregular bleeding. In the postmenopausal women, they will give us endometrial hyperplasia. When they have the Sertoli Leydig type, then you get some virilizing features. Within the sex-cord stromal tissue type, we also have the fibroma. And this one can give us an ovarian fibroma, which often will present with ascites, what we call Meg syndrome, when it is associated with pleural effusion. So this is another classification of the ovarian tumors, the sex-cord stromal type. So we will come back because you'll find in our discussion, our focus mostly will be with reference to the epithelial ovarian cancers, which are the most common. And this most often when people talk about ovarian cancer, they are referring to the epithelial type. But you have to keep at the back of your mind the other types that we mentioned. So these form around 80% of the ovarian cancers, and they are further subclassified depending on the behavior of the cells. These cells might be serous nature in type, meaning they secrete clear fluid, and they'll be termed serous carcinoma of the ovary. Sometimes they give us mucin, and they'll be called mucinous type. This one resembles the intestinal cervical epithelium, where we get this sort of cells, the goblet type of cells. Then we have the endometrioid type, which resembles the endometrial lining. And so it is called endometrioid carcinoma of the ovary. We have the others which resemble the transition epithelium of the bladder, and they are called the clear cell or mesonephroid. Sometimes you are unable to place in any of these subtypes we are talking about, or sometimes you even just get a mixed picture. You have a mixture of serous with endometrioid cells, or even some pockets of mucinous here. So it is not a must that it be one type, but usually when the pathologist will report, they'll give us the predominant cell type. Sometimes they are unable to place, then they will call the tumor anaplastic or undifferentiated. As we said earlier, our focus today is on the malignant type of ovarian cancers. But otherwise, when these tumors present, even when they are epithelial, they may be benign in nature, or sometimes they may show some what we call borderline. You cannot say it is malignant, you cannot say it is benign. Or sometimes they are frank malignant invasive disease. So a little bit more. I know this might not be very interesting, but it's just good to keep it at the back of your mind, because sometimes you come across this report and you need to know what they mean. So the serous type are also further subclassified into either high grade or low grade. This is just based on cellular differentiation. If you remember your histology, we would say cells are either well differentiated, moderate differentiated, or poorly differentiated. So when the cells are poorly differentiated, that or moderately differentiated, then that will be put under the class that is called high grade. This high grade, occasionally again, we'll call it type 1 epithelial ovarian cancer. Then the low grade will be classified as type 2. So these are just terminologies the pathologists will use, but suffice to say, the cells might be either well differentiated or poorly differentiated. So the serous type account for majority of the epithelial ovarian cancers, almost 70–60%. Then number 2 will be the endometrioid, which we have seen resembles the endometrial lining. And then we also have the mucinous. The mucinous type tend to grow to a very huge size. So if you find a woman with a very huge distended abdomen, with a smooth sort of surface, then most likely you are dealing with the mucinous type of epithelial ovarian cancer. And this mucin, when it spills, then it gives us what we call pseudomyxoma peritoneae, meaning mucin spilled into the peritoneal cavity, causing inflammation and adhesions. Clear cell, we had already seen that. Then, as I said, sometimes you are unable to place, and we call that undifferentiated. So a little bit about risk factors. What makes one to get ovarian cancer? I think the most important thing to put out, because when we have a presentation, often patients, when they get cancer, they are like, did I do something wrong? Is there something I didn't do? And even many of us would want to avoid cancer. But the most important thing to point out is that most of these cancers are sporadic, and it is difficult to pinpoint what really predisposed one. You find a young girl who now has this germ cell tumor. What made her to get it? Sometimes we do not have a specific predisposing factor, although we know they now occur in the young women. Or even if I find you are old and you have the cancer, what did you do wrong? You probably didn't do anything. So the majority are sporadic. Age is a factor. So women above the age of 50 years are at higher risk of developing ovarian cancer. And also when you are of less than 30 years, young age group. Then the other thing that has been shown is reproductive history, where we have issues to do with the fertility, low fertility, low parity, or having children later in life, meaning you've had a long interval of not bearing a child. So during that time, you've been having ovulation. And we know that there is a theory that if you have prolonged ovulation, a prolonged period of ovulation, usually you get inflammation around the ovary, and this predisposes to mutation during the repair of the cells. As you ovulate, there's damage to the ovary, the area repairs, and these cells can mutate along that repair pathway. Early menarche, late menopause, just that prolonged period, as we are saying, long interval of ovulation. Endometriosis has been shown, and this is usually where you have the endometrioid type of ovarian carcinoma. Body mass index, obesity, metabolic syndrome, I think this is where we now start to see the disease more in the affluent. Other possible risk factors would probably include things like diet, but this has also not been satisfactorily proven. Talcum powder, yeah. So I think what usually weighs strength is what we call the inherited type or hereditary type of ovarian cancer, which is a small proportion, just about 5 to 10%, depending on which mutation you are looking at. So we have two mutations which have been talked about and published widely, BRCA1 and BRCA2. And these ones give us a risk of between 20 to 40% for ovarian cancer. BRCA1 being on the lowest, BRCA1 having the higher side of around 40, and the BRCA2 being on the lower side around 20. Then we have a hereditary non-polyposis, the Lynch syndrome, where patients who have a non-polyposis colorectal cancer syndrome also tend to develop ovarian cancer. This one is seen in just about 5% of the ovarian cancers, while the BRCA1 and BRCA2 will see around 10%. So when you have these hereditary factors, sometimes we find even there's still the history of the family, because genes are the same. So if you have a family member who has had the ovarian cancer, 1 first-degree relative elevates your risk a little. 2 first-degree, we see it goes even higher. But if you have BRCA mutation, then the risk is quite significant. Now, in the first two that we are talking about, it does not mean there's a documented mutation. It just means that you share similar genetic makeup. So your risk for ovarian cancer is quite elevated from the general population, where we have around 1.5 to 1, sometimes 3%, depending on which population you are looking at. So are there things one can do that may be protective? We saw that low parity infertility, so the opposite of it is protective. If you carry pregnancies to term or high parity, then you have less ovulation intervals. Breastfeeding, we know, is suppressive of ovulation, and that again is protective. Use of oral contraceptives. This one has been shown, because when you suppress ovulation using the combined pills, then you do not suffer the mutation associated with the repair of the surface epithelium after ovulation. Tubal ligation and salpingectomy, primarily salpingectomy, has been shown to be quite protective, especially with the serous type of ovarian carcinoma. These cancers are thought probably to arise from the fimbrial end of the tube. So when you remove the tube and throw it away, then you'll find that is protective. Ligation per se, not so much, but people think maybe there could be migrating carcinogens like talcum powder going through the tubes. Lifestyle, we saw that with regard to body mass index. So we advise that one stays active and maintains an ideal weight and eats well. So healthy eating, so that you check your weight. So I think with that, we will now move on quickly to look at how patients who might be having ovarian cancer present to us. So we already saw, if it's a young girl, prepubertal, who might be having a germ cell tumor, often they will present to us with an abdominal mass, sometimes even pain, some irregular bleeding because of the hormones arising from this tumor, if it's hormonally active. But by and large, the symptoms for ovarian cancer are often vague and non-specific. And this often leads to delay because it's not that thing which really bloating, and you persevere. And so these symptoms will persist in spite of trying to persevere, as many people will do, and gets worse. And so you'll find by the time they're coming to us, the disease is quite advanced. Some things which have been mentioned include things like lack of appetite, early satiety. Sometimes if the mass is huge, then now it will start to cause some local pressure symptoms on the bladder and the bowel. So patients might get a bit of constipation, diarrhea, not so much, okay? If the tumor is hormonally active, then the change in the menstrual cycle will bring these patients to us. And this is often good, say, with the granulosa cell type of tumors, because since they elaborate estrogens, you'll find women will come to us maybe with postmenopausal abnormal uterine bleeding. If they're young, then they'll have menstrual irregularities, and then we are able to pick. But otherwise, for the other epithelial type of ovarian cancers, people do not know what is happening, and they usually think it's just an upset, and they try to take local remedies. And when you palpate, most likely because the ovary is still small, you don't feel anything. So there will also be issues of unexplained weight loss, and depending on where it has spread to the body, you may find some patients might come in with chest symptoms, sometimes swelling of the abdomen, or just ascites. Sometimes if the mass has grown, then they say, now I feel something growing in my tummy. So most important thing is to know that these often vague symptoms. So you look at the age categories. If the woman is postmenopausal, don't ignore. Try to investigate why this woman who has been feeding well, has been fine, in good health, now suddenly starts complaining of abdominal bloating and discomfort and loss of appetite. So in advanced stages, this is what we often see. And sometimes this can happen so fast, you find maybe a month ago, this woman was not like this, or 2 months ago, the abdomen was more flat. But like here, we can see this is a patient who has come to us with very advanced disease. So, and you find the history is just around 6 months, 3 months, 4 months of this sort of progressive abdominal distension. When the history is longer, say maybe 2-3 years, and the woman presents to us like this, then we may think maybe it is a benign. It might be having an ovarian tumor, but most likely benign. But for malignancies, usually it's just around up to around 6 months, and you have this. So when you examine the patient and you find she has this sort of a clinical presentation, then now you have to entertain differentials. And the differentials are many. They could be other abdominopelvic masses, which you can find in the abdomen, or you may find that she has a fibroids if she's young, or she has a GI malignancy with the possible obstruction, or just medical ascites. But what we see oncology a lot is a TB of the abdomen, tends to present like that, and also lymphoma. So when you are looking at this patient, don't just say this is ovarian cancer. Just also consider that this patient could be having other conditions which might be mimicking the presentation of ovarian cancer. And so that it is usually around here that we need to make the diagnosis, because how do you tell? Sometimes you'll find patients coming like this and they have been receiving TB treatment. Okay. So when it is unresponsive, or we start, so for us, before we start treatment, we must be sure that what you're dealing with is ovarian cancer, because these other things can also present like that. So how do you make the diagnosis? You need a high index of suspicion. You must take the history. As I said, usually these vague abdominal symptoms, maybe menstrual irregularities, okay? maybe abnormal bleeding in the postmenopausal women which has not been there, okay? So this will arouse your suspicion. Or she has ascites, she has effusion in the chest, then you're like, what could all this be, okay? So your examination findings will also be critical in terms of guiding you. So there are investigations which we normally do, tumor markers. Commonly you'll find as doing CA-125, which we find is elevated in the serous type of epithelial ovarian cancer, and maybe the endometrial. But otherwise, if it is mucinous, sometimes this CA-125 is within normal. Then if there are germ cell tumors, you're looking at things like alpha-fetoprotein or even HCG and the like. If the tumor could be from the colon, then you will be looking at things like CEA or CA-19-9. Then there is imaging. Imaging is usually critical because with this abdomen, which is looking like this, sometimes you palpate and you can't just figure out what is inside there. So imaging becomes useful, and you can start with a simple ultrasound, abdominal pelvic. We prefer you do an abdominal pelvic, not just pelvic, because the mass could be going all the way to the upper abdomen. So if you just focus on the pelvis, you might not see anything. Sometimes once we have this ultrasound, if we don't know what it is, then we'll proceed to do a CT scan. And the CT scan is quite useful because, especially if it's done with contrast, then we are able even to tell whether it could be a mass from the colon or from the ovary. So CT scan we'll do of the chest, abdomen, and pelvis. For the chest, it helps us pick chest mass. If not, you could do an MRI. I think now we are lucky in this country. Most of the time, by the time these patients come to us in Kenyatta, they've had this sort of workup. What we have as a problem is abuse of, say, like CT scan, because find anything small, somebody has done the CT scan without probably even considering what the ultrasound was showing. Sometimes patients come to us and the imaging findings, physical examination findings are inconclusive, and you may consider doing a diagnostic laparoscopy. Sometimes we tap this fluid and we send the specimen for cytology, and it tells you they are malignant cells. So when they are malignant cells complemented with the imaging findings, then you will want to probably associate the primary with the ovary if the imaging is showing some ovarian mass. Sometimes the disease, we find masses and we are not clear, or we do not have the histology and we don't want to open. Then we'll do an ultrasound guided biopsy of the ovarian mass or whichever mass that we have picked on imaging. Because of the vague symptoms of this disease, if you talk to the GI surgeon and a patient presents with this sort of symptoms, these symptoms mimic gastric CA, they mimic colonic CA. So it is usually very important that this patient gets some form of workup to rule out a colonic malignancy, because oftentimes we find maybe the patient, what they had as a primary was colonic and it has spread to the ovary. So when you do imaging, you are seeing an ovarian mass, but the primary was in the colon. So we recommend that you do some complementary endoscopy, either upper GI or colonoscopy, just to make sure that there is nothing you are missing within the colon. And that helps very well in terms of preoperative planning for treatment. So once you have all this, usually there are things which would suggest to you from the imaging, clinical assessment, that this, what you're dealing with could be an ovarian cancer. And so what are some of these? if you find on imaging what you're dealing with is a huge solid ovarian mass, then most likely you're dealing with a malignancy, possibly a germ cell tumor. Sometimes it is solid cystic, which the ultrasound people might just say complex mass. Usually they are bilateral when they are malignant. And you may find they have multiloculation, thick septation, papillary projections. These are findings the imaging people will give us. And using that, we are able to raise our index of suspicion for ovarian malignancy. If you have a mass and is associated with ascites or obvious peritoneal seedling, the imaging people sometimes are able to see that. Sometimes you find there's an irregularity of the mass, firmness, fixation when you're palpating. That will suggest malignancy. Sometimes you have a mass in the abdomen and you find there are mets already in the liver, in the chest, then that is probably a malignant process. Sometimes you pick knots. We've seen patients coming to us with the knots even on the umbilicus or even in the groin. Or you just told there's paraortic lymphadenopathy when the imaging is done. Of course, when you see knots, you have to now start considering, could it also be a lymphoma? And so you will now need to just keep that at the back of your mind. So when patients have this sort of malignancies arising from the ovary, they tend to spread all over the abdomen, just local spread as the cells peel off the ovary and drop in the pelvis. Sometimes you have a lymphatic spread to the regional nodes and even distant. We've seen patients coming to us with supraclavicular nodes, and often we are able to even make the diagnosis without doing a laparotomy, just by doing lymph node, either biopsy or excision of the supraclavicular node or whichever node that is there, and starting treatment. Hematogenous dissemination is there, but is not the commonest, but it does occur. So what things would you see when you examine the patient that would suggest that this patient could be having distant mets? It could be ascites, it could be carcinomatosis, which is reported on imaging, or just extensive disease in the abdomen. The burden of the disease in the abdomen would tend to tell you that this patient probably could be having mets. Retroperitoneal nodes, yeah, sometimes they're involved. So if the patient has this sort of extensive abdominal disease, it is important that you do a chest CT or on the minimum a chest X-ray to rule out chest disease. So now that we have reached a point where we have this patient whom we suspect could be having an ovarian cancer, how do we manage them? Management is usually a team approach, and usually the team lead will be the gyne-oncologist. Often we work together with the medical oncologists, radiologists, pathologists, general surgeons, counselors, nurses, to be able to give optimal care to this patient. The most important thing is to discuss the first approach. Is it going to be primary surgery, or what are you going to do? So this is usually discussed, and we are able to come up with what we feel would be the best approach in terms of care for this patient. There will be other things to consider, of course, the general status of the patient, the age, reproductive concerns, especially for the young girl who comes with an ovarian tumor. What sort of surgery are we going to do? Usually here we are considering fertility conserving surgical procedures, and we must decide which one. Stage of cancer is important in terms of decision making. The usually histologic type is something we'll come up with after the surgery, because often before surgery, we don't know what histologic type we are dealing with. And the management of every patient is individualized. There's nothing like, since this was done for so and so, is a repetition of the same. We assess each patient and decide the care based on that particular individual consideration. So what is the role of surgery? Surgery is usually the mainstay treatment in ovarian cancer, because often these masses are huge and chemotherapy alone will not be sufficient, or it might not even work. So whether it is early stage or advanced stage, surgery has a role. The role ranges from diagnosis, because as I said, you just have an abdominal mass, you even don't know what it is, but you suspect it's ovarian. It is when we do laparotomy that we actually confirm, hey, this was actually a tumor rising from the ovary. Sometimes we find totally different things. Then during surgery, we are able to do comprehensive staging. We remove the tumor as much as we can. Often we want to leave very minimal or hardly any tumor in the abdomen. But of course, when the patients come late, then this is hardly visible. The first surgery is the most important because this one gives the patient the best chance of survival. I didn't pick that slide, but you'll find if you leave a lot of tumor in the abdomen, then the survival chances of the patient are markedly reduced. So we want minimal residual disease at the time of surgery. And this has been cited in literature as less than 1%. People now are talking of zero visible disease. So this is just a specimen to show you what sometimes we get. This is like a huge ovarian mass. You can see the surface is already seedly, and usually it's multi-septated and vascular. This is another one. This one now, the surface sort of looks smooth. This is omental tissue, which we normally remove together with the hysterectomy. So we have various staging and cytoreductive procedures that we'll do during this surgery. I think it is just important to know that once we have made the diagnosis, then often we will go for surgery unless there's a contraindication. So these are patients, again, you see, sometimes you are not so lucky. Here we were able to do maybe optimal reduction, but like in this patient, you can see what we normally call an omental cake. This is a patient you open and you just find tumor all over. This is the normal omentum filled with the tumor, and you might hardly proceed beyond the omentum. So sometimes you just come out with this, you take for histology, you get the results, and you start the patient on chemo. So during surgery, we are able to stage the disease, and stage 1 is usually disease which is just confined to the ovary. Sometimes there is, or there might be no ascites. Stage 2 now is disease which has gone beyond the ovary, which is the primary organ, to maybe the tubes, the uterus, the bladder, or the sigmoid colon, which are just in the neighborhood. So this is still disease confined to the pelvis. Sometimes we find now the disease has gone beyond the pelvis, where the ovary is located, to the abdomen, like now here where we have omental caking. So that will be stage 3. And stage 4 is when the disease has gone out of the abdomen, disease in the chest, or there are even liver mets, bone mets, vaginal mets. So you can find mets all over in this disease. So what do we do? What is the role of chemotherapy after surgery? Chemotherapy is very important because often you'll find a majority of the patients will have residual disease, either microscopic or macroscopic. And therefore, we need chemotherapy to clear the remaining tumor cells. And so there are certain drugs we use, and often what has been shown to be very effective are the platinum compounds and the taxanes. So we often start them on first-line chemotherapy, which is usually a combination of either carboplatin, cisplatin, carboplatin with the paclitaxel, or cisplatin with the paclitaxel. Or you can use carboplatin or docetaxel. Either of them is okay. Sometimes we do what we call neoadjuvant chemo. This is where the patient's condition is so down. This is a very sick patient, you feel you can't even take to theater. Or the disease is so advanced, we feel we will not be able to operate. So this is where we say we can do an ultrasound-guided biopsy. And once we have confirmation that this is ovarian cancer, then you start on chemo. No patient should be started on chemo, neoadjuvant chemo, without a histologic diagnosis. Histology is very important. So, chemo can be given as neoadjuvant or adjuvant. Adjuvant is after surgery. The chemo regimens are many. Here I've just listed some because often after first-line treatment, patients, some will get complete response, others get a partial response, others get disease progression and you have to go to second line. Others have recurrence later on during follow-up. So these are some of the drugs that we may use either a second line or during disease recurrence. The other newer agents, they are called the targeted therapies, usually the vasoactive agents like bevacizumab, which inhibit angiogenesis, or tyrosine kinase inhibitors. So these are products which are available now, and we use them mostly, like now in our setting, we use them as second line therapies. So can this disease be prevented? Really, I would say there is no sure way of preventing ovarian cancer. What we just have to do is to try and minimize the risk. And often this, of course, for the individual who has no genetic predisposing factors, you just live a healthy lifestyle, okay? But there are people who we know have a genetic predisposition, family history. Then if we have a documented mutation, you can do a prophylactic salpingophorectomy. These patients also can use birth control pills to reduce the ovulation episodes, which increase the risk. So if there's a family history, you can do genetic counseling and testing, and if it's documented, then you will be put on a program of care. Screening, there is no screening test for ovarian cancer because the ones that have been tried have not been shown to yield anything positive. So we are still grappling with that. But where you have high risk for this disease, say you have a genetic mutation, then we recommend regular follow-up. And even any just other woman, as you come for your checkup, will do this sort of things to see if there is an issue. I think that we have seen. So after treatment, normally most of these patients will put on follow-up, and follow-up is lifelong because often there'll be disease recurrence. And so we need to be able to pick it up. During follow-up, a patient should be able to maintain healthy living, exercise, and quit predisposing things like smoking, alcohol intake, and the like. So survival, if a patient has a patient with ovarian cancer, often they come in stage 3. So survival will be in the range of 60–70%. But if it's early, we find the germ cell tumors, which we find in the young to pubertal girls, tend to have a better outlook. Often they are in stage 1, or maybe granulosa cell tumors, which come early. So the survival will depend on the stage, the histologic type that you're dealing with, and the response to the chemo, because not patients respond to chemo differently. You may have the same histology, but the response to chemo is different. If you get a complete response, good for you. Sometimes you don't get good response, then we are in trouble, and that will impede your survival. I think maybe Julie will talk about that. So I will end there, and because we are short of time, allow Julie to do her presentation, then we can see the questions which are there and respond to that. Hello, Roslyn.
Thank you very much, Dr. Musalia. That was a very good, informative presentation. We have learned a lot. You deserve a round of applause. I'm sure you'll get it as Julie is uploading slides. And we also have quite a number of questions that have been put up to you. You
Yes.
look at them, and then once Julie completes the presentation, we'll quickly go through them. Thank you again.
Okay.
Welcome, Julie. I'm able to see your slides. As I told you earlier, oncology with the manager of the Clinic 66, as we call it within KNH, where we do the cancer screening. And there's a lot that she has in store for us today. Kindly log in and also put for her the questions. We'll take them up after the session.
Good afternoon.
Good afternoon, Julie.
Thank you, Roslyn. My name is Julie, like Roslyn has mentioned. Today we are going to look at the nursing management in ovarian cancer. Dr. Musalia has really given us good details for the medical management. But my role this afternoon is brief, just to give highlights on what is expected of a nurse, especially an oncology nurse. So in oncology nursing, we take care of the patient even before diagnosis, right through treatment to the follow-ups. Follow-up care is also very key. So before even the patient has been diagnosed, the nurse should be involved, or even the counselor, so that they walk this journey with the patient. Usually in Kenyatta National Hospital, these patients are diagnosed and they are given nurse navigators who work with these patients right from the first day they are seen in the clinic, through the treatment, and even during the follow-up. Sometimes they even go beyond because they need to take care of the family, they need to take care of the friends, you know, the extended community. So the role of the oncology nurse, I did this generally because an oncology nurse will take care of an ovarian cancer patient, of a cervical cancer patient, and any other oncology patient. And the first thing they need to do is take the patient's history. And this should be detailed history so that they get good information about the condition. Like Dr. Musadi has said, some of these symptoms are like any other symptoms in any other illness, and they can easily be missed. And then they also need to assess and monitor the patient's physical and emotional status. This is very key in oncology again. Sometimes we do it we generally do it in our patients, but in oncology, a physical and an emotional status must be assessed because these patients have gone through a lot. By the time they get the diagnosis, I will tell you it is not very easy for them. Then we also keep track of the laboratory pathology and imaging studies. Dr. Msali has given us details of what is expected in the investigations. But this patient has been sent to the lab. She doesn't know where the lab is. She has been sent to the imaging, to radiology. She doesn't know where that is. That is also a nurse's role, just to explain what is expected of her, of the patient, and even the results that may come up. Safely administer medications. Now, after the diagnosis has been made, of course, we were told it's after a biopsy. Without a biopsy, we cannot confirm a cancer or a malignancy. So we, as nurses, ought to administer the medications safely because these are cytotoxic drugs which are very toxic. If mishandled, they can cause the staff to get even cancer. Fluids and cancer treatment also, this is of course part of the administration of medications because we do pre-meds, we do very key for the benefit of the patient. Collaborating with the patient's doctors and other clinicians about the treatment plan. Again, Dr. Musalia talked about a multidisciplinary team. This is usually a very big team. All these people are coming to take care of one patient. So the nurse acts like the advocate. because she will liaise with the gynecologist, he will liaise with the medical oncologist, the nutritionist, even the family, because the family are key in the management of these patients. Another thing the nurse will do is help the patient understand the disease and their treatment plan. These patients come in not knowing what is going on in their body. Right from the word go, they are not feeling well, they have already started losing weight, they cannot sleep, they are depressed, they are anxious. So the nurse needs to assess and understand this patient according to their disease. Again, this is individualized because even every patient, no matter the diagnosis, is an individual, and we are supposed to treat them as individuals. So we need to understand them and try to explain to them the process, the disease, in a language that they can understand. Sometimes we go wrong and we address the relatives. If it is an elderly mama, you don't even want to tell her diagnosis. But it is the role of the nurse to give this information in a way that the patient can understand. We translate complex medical terminology and even answer questions. One thing a nurse needs to know is know the disease. It's good to understand what this disease is all about. If it's ovarian cancer, let them go into details and see. As an individual, find out what you know so that when you're explaining to this patient, you're able to translate the complex terminologies that go in with the disease and even answer their questions. Sometimes we assume that this patient does not understand, this patient does not, will not be able to comprehend what is happening, but you will be surprised once you explain to them and you answer their myths and misconceptions on what they have had out there, then it helps the patient a lot. Communication is also very key with the patient and even with the healthcare workers taking care of this patient. Not to mention, we are supposed to help the patient plan for and manage symptoms throughout the treatment. In nursing, we call it the nursing process, where we assess, we plan, we implement, and even evaluate the patient's care. So one of the things that we help them do is to plan. And we can plan with them because we don't plan for them. Nowadays, we have patient-centered care. And so we plan with them and help them manage their treatment. So some of the responsibilities of the oncology nurse include, number one, you assess yourself, your own knowledge of the disease process, like I mentioned. You need to understand this disease so that you're able to explain to somebody else or even to that patient and their relatives on what they expect. Make use of the current research findings and practices in care of the patient and their family. This is called evidence-based practice. Once researches are done, we're supposed to implement these researches into our practice and so that we can improve the quality of care that we are giving. Remember, at the end of the day, for this oncology patient, for this patient with ovarian cancer, like we have seen, they have a very big mass, which has been, growing very fast. So we need actually to improve their quality of life. For them, they just want to be pain-free. For them, they want to, be comfortable, be able to do their own thing, which is an uphill task for them at the moment. We're also supposed to identify patients at high risk for cancer. In oncology, we take care of the patient, like I said, before diagnosis. So even knowing who is at high risk, because we've been told the risk factors that are associated with ovarian cancer, it is good to identify some of these patients. Participate in primary and secondary prevention efforts. Unfortunately, for ovarian cancer, there is not much screening, like Dr. Musali has mentioned. The best we can do is maybe when somebody has maybe some symptoms like constipation, bowel obstruction, urinary frequency, abnormal bleeding, nausea and vomiting, some of these things you just investigate further so that you can see where exactly the problem is. Then as a nurse, we assess the nursing care needs of this patient. The doctor has already addressed so many needs, but there are those that the nurse in particular is the one who is responsible for them. some of these are just minor, but very critical for this patient. So assessing the patient is one of our roles. Then we also assess the learning needs. What is the patient, what does she want to know? How do you explain to them? Are they able to even comprehend? Are they able to, what do they want? Severally, we find that we don't ask the patient what they want. We already are planning for them. But now things have changed. We are going to look at how the patient, we are going into looking at how the patient would like to be treated. You know, I remember once I met with a patient who didn't want to be started on treatment. You can imagine you're diagnosed, you'll be told all the pros and cons, but she decided, no, I'm not getting any chemotherapy. I'd rather die peacefully without suffering. For her, it was suffering. So sometimes listening to the patient and their desires and capabilities of the patient is very key. Other responsibilities include identifying nursing problems of the patient. Like I said, we use the nursing process where we assess, we identify the problems, we make a nursing diagnosis, and we try to take care of the patient as best as we can. But just identifying what the problem is and what the patient really wants and what the family feel is very critical, especially for the nurses. Assess the social support networks available to the patient. Again, this patient came from the community. This patient has been going to church, she has women groups, she has family, extended family. So these are people who can actually support her. So identifying and trying to bridge the gap between the community and the patient is very key, so that when the patient is discharged or she needs to go home, she's able to go back to the community and blend in like normal. We're supposed to plan appropriate interventions with the patient and their family. We need to involve these patients next of kin or the significant others in the care, because these are the same people who will be caregivers in the home. These are the same people who will take care of her when she gets to the community. She needs the support from the family, and identifying, it is best even to identify a key person in the family, either the spouse or an elder child, who can be identified to take responsibility of the patient. The nurse is supposed to assist the patient to identify strengths and limitations. Some patients are very, they have very challenging problems, but you find their limitations for even their illness. For example, if you don't have an NHIF insurance and you have been diagnosed with cancer, and you don't have the finances to take care of this treatment. So it would be good to let the patient know if they are not able to, get an NHIF cover, they can go to the church and ask for funds. Or if they have a job and they don't know about the NHIF, you can just ask them to enroll and apply and start getting the services of the NHIF cover. The nurse will assist the patient to design short and long-term goals for care. Sometimes we assume, sometimes we may assume that the patients know, but most of the time they don't know. Because like I said, the NHIF could be a long-term goal, because now in future the NHIF will mature and will be able to cover the treatment as the patient continues in the continuum of care. And short-term goals would include, how will I get to the hospital? How am I coming to the next clinic? Help the patient identify and design ways of working around their treatments. The nurse is supposed to implement a nursing care plan that borders with the medical care. That one is almost self-explanatory. What you're planning for this patient moves along with the kind of treatment they're getting. For example, you would bring a nursing care plan for a patient who is going for surgery. We have seen the kind of patients we are dealing with in ovarian cancer. They need a lot of care pre-surgery, so that even after surgery, they'll be able to, cope, they'll be able to manage their problems adequately. There are many responsibilities. We'll continue how to collaborate with the multidisciplinary. Like I said, the nurse is more of the patient's advocate. She's the one who liaises with all other members of the multidisciplinary team and fosters continuity of care. And then not to mention, after all this, you have talked, you have educated the patient, you have planned for them, you have given the care. You also need to evaluate, because what you're doing, you need to look back and see, are we doing good? What is the outcome? Have we improved the patient's quality of life? Have we reduced their pain? Have we reduced their psychological distress? And then eventually we reassess and we restructure the direction of care after the evaluation. Of course, we work in tandem with the doctors, we work in tandem with the psychologists, we work together with the nutritionist, just to make sure this patient is comfortable, especially if they're having issues of, you don't have appetite, you have been told. Sometimes they're depressed, sometimes they're anxious, they are very weak because the drugs have made them, have immunotherapy, immunosuppression. So all this involves us taking care of the patient totally. Now, I just decided to put a few nursing diagnoses, because we are nurses. Sometimes we need to be reminded that we have nursing diagnoses for care. One of them is anticipatory grieving. This patient has just been diagnosed with terminal illness. But in oncology, we don't call them terminal illness. She has been diagnosed with an illness. And then she needs that psychological support. She needs to be counseled. She needs all the support that she needs as she starts her treatment. She may develop situational low self-esteem. If you look at the diagrams, the pictures Dr. Musalia has shared, of course, with such an abdomen, you won't even want to leave the house. You won't want to, you'll be wearing clothes that can almost cover that, so that she has developed that low self-esteem. The abdomen is distended, therefore it's stretching and it's pain. So we try to address the pain. There is altered nutrition. We were told this patient has no appetite. She has satiety, which is very sudden. She's not able to pass urine, or so she's not comfortable. She's not able to feed. During treatment, there is nausea, there is vomiting, can develop diarrhea. Then there is, of course, risk for fluid volume deficit. Other nursing diagnoses include fatigue. There is risk for infection. Remember, she is immunosuppressed, and she has all these IV lines being put because of the chemotherapy. She has undergone surgery, major surgery. All this can cause infection. Others include the mucous membrane may be altered, this for impaired skin integrity, this for constipation. Sometimes they even have constipation, it's not just risk for. There's risk for altered sexuality patterns. Of course, the patient has undergone so much, so her sexual function will be altered. This for altered family process. This was a woman who was in the community. All of a sudden, she's very sick, nobody to take care of her. Because even as they start coming for follow-up, there are questions of, what if it relapses? What if I start all over again? So these are some of the things that we take care of as nurses, and we try and make the patient as comfortable as possible. That is our role as nurses. And to conclude, this is just a diagram and a quote that you can't always save people, but you can love them. So let us love our patients, let us make them comfortable and improve their quality of life. Not only the patient, even the family. And that is what I had for you. Thank you.
Wow, thank you very much, Julie. That is well presented. We are giving you some rounds of applauses. You may not be able to hear, but you've done a good job. From the beginning of presentation up to now, we have learned quite a lot, from the classification of ovarian cancer to the risk factors, to the signs and symptoms, and the differential diagnosis. One of the things that struck me is when Dr. Musalia was talking about the differential diagnosis. Some of us, whenever we see ascites, we come into conclusion. I've had a patient who was diagnosed almost visually by ascites. Unfortunately, it was they failed to look further, just realize the patient had a GI malignancy. So it's important that as much as we're able to think about to have that high index of suspicion, you need to do histology, just the way we have been reminded throughout the presentation. We have been told on the sites of MET and on the management of ovarian cancer, which includes chemo and surgery. And Julie has then taken us through the nursing process very well. And now we know that we have lots of issues that goes through a patient's mind and the family. Can you imagine you are once the breadwinner and suddenly you can't make a decision? Every other person seems to be telling you what to do. It's a very difficult situation. The nurse is telling you what to do, the doctor is telling you, and somehow you're not even given a chance to think. So we need to be more considerate when we are talking to our patients, as it is going to impact on their ability to even adhere to our treatment. And as Julie was talking, then I remembered we have chemotherapy. Chemotherapy was mentioned as a neoadjuvant. Also, as an adjuvant, we have docetaxel, paclitaxel, or rather the taxanes and the platinums. Some of these platinums and taxanes really come with a lot of side effects, which may not have been mentioned in this, this session, but you can look out and see that each chemotherapy session needs a lot of support in terms of containing the anemias that comes with it, containing the cachexia, and ensuring that the patient is able to adhere and come. And even if you get into the second line, like the targeted therapy, then you'll be able to support up to financially. So thank you again, Dr. Musalia. I hope you are now seated next to your microphone. You have quite a number of questions. We'll see how many we can answer. There's first, there's somebody who asked a question at around quite early in the presentation. And this was quite a lengthy one. If you compare the generation with the 10 to 15 children with the current generation for prevalence of ovarian cancers, what should you advise on prevention? Is it possible to wake up the ovaries of elderly prior to menopause to continue being reproductive? Okay. And then that is our question number one. Then another question is, does birth control ovarian cancer? Then any prognosis data from Kenya, and what is the source of the 5-year survival rate? So you can take those 3 questions, Dakari. Also post questions.
Okay, thank you so much, Roslyn. Yeah, I agree. There are many questions and comments on the chat box. In fact, one would probably need a whole evening to be able to go through all of them. But just quite interesting, showing you that this disease is here with us and we would like to know more, but there's still so much more to be known that you cannot be able to conclusively discuss everything within 30 minutes. But that aside, I think somebody who asked, I've seen a question on pills. For sure, pills have been shown to reduce the risk of ovarian cancer. In fact, what has been shown that is that if you use pills for up to 5 years, non-stop, then you reduce your risk of ovarian cancer by almost 50%. So, and it is because of what I said in terms of the theories surrounding this disease, especially when we are dealing with the epithelial ovarian cancer, that every time a woman ovulates, there's injury on the ovarian epithelium and there is repair. So during the repair, you get mutation of the cells, and there is mutated cells that occasionally become malignant. So if you prevent ovulation, then you're able to reduce your risk of ovarian cancer. And that is how pills work. Because when we use the combined pills, then we do have an ovulatory cycles. So that is how they prevent. There was a question on 5-year survival and the source of this data. I think what I would like to say is that we have our cancer registry. We are now just trying to document outcomes in terms of survival in our institutions like KNH. We have fellowships, and part of the research we do is to look at the outcomes of the patients we are managing, long-term and short-term. So that is where we get this data. There was a question on does tapping of the ascites help the patient? Very true, because when you have that markedly distended abdomen, it is uncomfortable. You get a lot of discomfort, breathlessness. So if you tap, then you relieve the abdominal distension and the patient gets a lot of relief. And then also in terms of chemo, when we are giving chemotherapy, often the chemo gets diluted by accumulating in the peritoneal fluid. So if you reduce the amount of peritoneal fluid, then you are able to have adequate concentrations of the drug and improve your response to chemo. There was a question on, I think it is here, if you compare old generation with the current generation for prevalence of ovarian cancer, and whether a woman delivering up to late in menopause reduces the incidence. I think when it comes to delivery, you don't have to do 10 to 15. In fact, even one delivery is protective, 2, okay? The problem is having no delivery at all. What is not protective is when you have a long interval of reproductive life. That is, you had early menarche and you had late menopause. So you had a long period of ovulation. That one is not protective. That one is in fact a risk factor. So that women who go into late menopause tend to have a higher risk for ovarian cancer. So that one is like that. It is, the delivery itself is protective, but a long reproductive life in terms of early menarche and late menopause puts you at risk. Can a woman get ovarian cancer after hysterectomy? Yes, they do get. In fact, when a woman just has a simple hysterectomy where maybe she had fibroids and you go in, remove the uterus and leave the ovaries behind, that woman is still at risk of ovarian cancer. And what we are advising now, I think this is mostly for the gynecologists, that when you do a hysterectomy, you remove together with the tubes, because often we would cut the tube halfway, so it is left in the abdomen, and that increases the risk for ovarian cancer. But if you are doing, you may leave the ovaries behind. Whether to remove them or not, usually is a balance, depending on the age of the woman. Usually if a woman is near 50 or above 50, then you'll come out with the ovaries. But women, say a woman who is in her 40s, then if you remove her ovaries, you drive her into early menopause, which puts her at risk of other morbidities associated with the early menopause and lack of estrogens. Thank you. I don't know whether there's another one you'd like me to respond to, Roslyn.
Well, thank you for the responses. So somebody's asking one more. How long does it take to get BRCA test results? And then another question, you know, people saw the surgery and the samples you are coming out with and a lot of info around it. So is it advisable then to refer these patients to gyn-oncologists at tertiary hospital instead of the primary surgery being done by gynecologists, especially in the county facilities? And we have the capacity to currently handle these cases.
Yeah, I think at the moment, we are growing our capacity quite exponentially. If say somebody is in Western region, at Kisumu Teaching and Referral Hospital, we now have a gyne-oncologist who can be able to attend to women in the Western region. Around North Rift, there is Moi Teaching and Referral Hospital. So women can be referred there and they'll have optimal surgery. Then if you come towards the Central Rift and even Nairobi area, KNH and Kenyatta University Teaching and Referral Hospital are quite accessible. Coast Province, we have gyne-oncologists there. So really, I think maybe we need to share more information on the availability of gyne-oncologists. We are not saying every gyne surgeon. We are just saying where there's high index of suspicion that the mass you're dealing with could be a malignancy of the ovary, then it would be best be done by a gyne-oncologist. But otherwise, if you have a benign ovarian cyst and we know the features, any gynecologist who has gone through training must be aware of how a benign ovarian lesion is supposed to be, even on ultrasound and the like. So they can open the others, but for what is obviously malignant, it is best referred for optimal outcomes. And the workload can be dealt with adequately.
Thank you very much, Dr.
Yeah.
I would want...
Hello?
Normally, sorry, I would like to remind us that normally we have tumor boards.
Yes.
And somebody in Kisumu can be able to get in touch with somebody from Eldoret or the team from Nairobi. Then they can be able to discuss the patient and have the right surgery performed. As you remember, you clearly stated this differential diagnosis so that you do not go into ovarian, then it's a CA colon with met.
Sure.
That was a personal story. So that is almost bringing us to the end. I am seeing Mr. Charles Muya from KNH-UoN. I'm not sure if you'd want to present or say one thing as you wind up. And Dr. one final question from our student here.
Yes. Hello?
She's asking, please clarify the use of hormonal pills in relation to breast cancer and ovarian cancer. Let's take that one as the last one. Then we just wind up.
I think pills, as I said, are protective of ovarian cancer. And the way they are protective is that they reduce the amount of ovulation. But of course, with the breast cancer, we know estrogens tend to lead to greater breast cancer tissue proliferation. So they may not be protective there, but with the ovarian cancer, it is very clear that they are protective. So if a woman has the inherited risk for breast cancer, ovarian cancer, often we'll put them on pills because usually the pills have low estrogen levels than what you produce biologically. So although they might be increasing a little bit your risk of breast cancer, but not as much as the natural risk, which would be there by normal ovarian function. So women who have documented risk for BRCA mutation, which is a hereditary ovarian cancer syndrome, then we will put them on pills. They'll go through childbearing, and we will probably advise that they do a prophylactic salpingoophorectomy as soon as they are through with the childbearing. Now, the issue of testing for BRCA mutation and turnaround time, I must say, I think this is something within the country. We've been discussing this in tumor boards, even within the private setups. We haven't set up the lab, so the specimens have to go out of the country. And that sort of gives you a long turnaround time. But again, there are a lot of issues to do with counseling when one opts for this sort of testing, because remember, it is not as easy as it looks. Confirming that somebody has that mutation can throw the whole family into disarray. So they need to go through a lot of counseling before finally they consent, and then the test can be done. Thank you.
Thank you again, Dr. Charles from KNH-UoN, would you like to give us a word?
Thank you.
Oh, thank you, Charles. Just go ahead.
Thank you so much, Roslyn. I don't have much to say, just to thank our speakers, Dr. Musalia and Julia. Thank you so much for the informative session, and also to thank our participants for joining us today and being active on chat and asking questions. The webinars are brought to us courtesy of Janssen Pharmaceuticals. And next month, we are going to be looking at leukemia. So you're welcome to join us as well as we continue running. Thank you very much.
Thank you, Charles. I would like to thank everybody who attended today. Thank you so much, my colleague Julie. Thank you, Dr. Musalia. We are all based in KNH, and we also have other colleagues around the country who are able to give equivalent care. So I would like to tell you to keep watch on this KNH emails so that you can be updated on our next webinars. And we have several conferences coming up in cancer this year. We have Oncology Nurses Chapter Conference coming up in Kisumu next month from 21st of September, 23rd. We have Kenya International Cancer Conference coming up in November. So we really need to talk a lot about cancer, create awareness, take screening where possible, because we have the National Cancer Guidelines on cancer screening. We can look out for them online and just ensure that we seek for screening on the cancers that are amenable to screening. For example, breast cancer, cervical cancer, and even colon cancer, as per the guidelines. Thank you very much again, KNH, for giving us this platform. Thank you to the directors and every leadership within KNH for the opportunity, and more so to the participants. Mjipigie makofi tukisema asante sana.
Okay, thank you, Roslyn, and your team for your presentation. There have been requests for the webinar slides and the webinar recording. Kindly note that you will be able to revisit this session once it has been uploaded on the KNH website. Just go to KNH website to the webinar tab, and then you will select this session, which is ovarian cancer. For the CPD points, nurses, your CPD points will be sent within 2 days. So you see your CPD, the attendance list will be sent to the Clinical Officers Council, and they will update it to the portal, so you can always be checking on the status of your CPD points on the portal. For KNPDB, you will be sent your CPD points via email. And for PPB, the CPD points will be sent via email as well. Although the sessions will be uploaded to within this week, so just keep visiting the portal and subscribe to the previous events that you did attend, and also the ones that will be uploaded, and you will receive your CPD points. Thank you so much for joining. We will be resuming our sessions next week with the part 2 of the pre-workshop sessions on pediatric hematology. And we will be focusing on childhood solid tumors. And then Wednesday 7th, we'll be looking at pain management, the use of NSAIDs in pain management. So thank you so much. We hope that you will join us next week. Do have a wonderful afternoon.
Thank you, Nelson.